full screen now.
Thank you for the introduction, and I would like to thank you for giving me the opportunity. So, ocular trauma is one among the leading causes for reversible and irreversible loss of vision, and it includes globe injuries, optic nerve head injuries, and as well as adnexal injuries. Now, injuries of the eye can be broadly divided into mechanical and non-mechanical. What we are concerned today are with the mechanical injuries and the non-mechanical injury, particularly the chemical injuries. Now, the setting of the injuries most commonly occur during daily activities, followed by road traffic accidents, sports injuries, physical assault, and agricultural industrial settings. So, the victims of the daily activities are mostly children, and the mode of injury can be with a pencil or with a knife, gilli danda, or a bow arrow while playing with bow and arrow. So we need to know the terminology of the mechanical injuries before we proceed. So eyeball, it is considered as cornea and sclera are considered to be eyeball, and not all the codes of the eye are equivalent to eyeball. So a breach in only the sclera will be equivalent to a breach in the eyeball, and it need not be a full breach of the choroid as well as the retina. Closed globe injury will have no full thickness wound of the eyeball, and open globe injury will have a full thickness wound of eyeball. Now, contusion injury is one in which there is no wound in the eyeball, but it occurs with a blunt object. Whereas lamellar laceration is a closed globe injury where there is a partial thickness wound of the eyeball, which is not penetrating full thickness, and it is caused by a sharp object. Now, rupture is a full thickness wound of eyeball, which occurs due to blunt object, and laceration is a full thickness wound of the eyeball, which occurs due to a sharp object. Now, penetrating injury, intraocular foreign body, and perforating injuries are the types of open globe injuries, laceration type. And penetrating injury has a single entrance wound, while a perforating injury has separate entry and exit wounds for the same sharp object. Whereas in intraocular foreign body, there is a single entrance wound and there is a retained intraocular foreign body. So this is how the Birmingham eye trauma terminology classification system divides the globe injuries into open and closed globe. The closed globe can be further divided into contusion type and lamellar laceration. Open globe is divided into rupture and laceration is further divided into penetrating, intraocular foreign body, and perforating types. Now, next classification system is the ocular trauma classification system, because BETS doesn't prognosticate the case based on the baseline variables. So we have the ocular trauma classification system, which gives the classification system based on type, grade of injury, pupil findings, and zone of the injury. And then there is an ocular trauma scoring system as well for prognosticating the case. So in closed globe injury, the type of injury can be contusion, lamellar laceration, and in addition, there is type C and type D type of injury, which is superficial foreign body and mixed. Pupil can be a positive response or a negative response based on the presence of afferent pupillary defect in the injured eye. The grade of injury is determined by the presenting baseline best corrected visual acuity, and the zone of the injury in closed globe injuries can be divided into three. Zone 1 being the bulbar conjunctiva and the sclera and the cornea. Zone 2 being the anterior segment, and zone 3 anything beyond the posterior lens capsule, that is the posterior segment. In an open globe injury classification, you have different types such as the rupture, penetrating, intraocular foreign body, perforating, and mixed. Pupil and the grade of injury remain the same. In zone 1 is involving the cornea and the limbus. Zone 2 is from the limbus to 5 mm beyond the limbus into the sclera, and zone 3 is anything beyond 5 mm from the limbus. So ocular trauma score, it allows for prognostication based on certain baseline variables. So based on these variables, we can predict what is the likelihood of visual acuity, what is the probability of the final visual acuity gain. So it depends on the initial visual acuity and certain anatomical parameters such as presence of rupture, endophthalmitis, perforating injury, retinal detachment, and afferent pupillary defect. So this is how we calculate the ocular trauma score. Based on the initial presenting visual acuity, we have the initial raw score ranging from 60 to 100, and then based on the presence of the anatomical factors, we subtract from 60 to 100 these points, and then we have the final raw score. Based on the final score, we have 5 categories of ocular trauma scoring, 1 to 5, and then we can, based on this table, we can predict what will the final visual acuity of the patient at 6 months. So coming to the mechanism, how closed globe injuries cause globe trauma cause injury to the eye. It can be by coop injury at the direct site of trauma, or counter coop, that is diagonally opposite to the site of trauma, and because of the shearing force between the easily extendable eyeball and less extendable ocular tissues such as the vitreous, iris, and ciliary body. So contusion injuries can range from subhiatal hemorrhage to hyphema, angle recession, iridodylisis, lenticular injuries in the form of rosette cataract, subluxation, dislocation. Then we have retinal dialysis, giant retinal tears, and Berlin edema. So the seven classical rings of ocular trauma that occur after blunt injury include the radial tears in the iris sphincter, then iridodylisis, angle recession, then cyclodialysis, trabecular meshwork tears, zonular dialysis, and retinal dialysis. So lamellar, coming to individual injuries, lamellar laceration needs to be differentiated from a full thickness laceration, and a serial test helps us in differentiating it. And if there is no full thickness defect, these lacerations may be observed. Superficial foreign bodies often occur in workplace settings, and these commonly occur without the use of protective eye gear. Rupture, the most common sites of rupture are those which are inherently weak, such as the limbus, previous surgical wounds, and the areas of scleral thinning beneath the insertion of recti muscles. Overt rupture can be easily identified by the visible rupture wound and prolapse of the tissues, but occult rupture, it is often difficult to identify the underlying rupture, and the pointers can be a jelly roll chemosis and a step sign in conjunctiva or a subconjunctival lens. Intraocular pressure is often low in such cases. Penetrating injuries can have tissue prolapse, and they can occur either in the cornea or in the sclera or both. Intraocular foreign bodies cause injury to the eye by either the mechanical injury from the foreign body or by introduction of the microorganism and endophthalmitis, and by specific action on the intraocular tissues by toxicosis. So types of foreign body can be reactive or non-reactive. Among the reactive metallic foreign bodies, we have the iron, copper, and zinc. And among the reactive non-metallic foreign bodies, we have the vegetative matter and the cilia. And rest of the foreign bodies are usually inert, such as glass, plastic, silica, silver, and gold. Now, occult foreign bodies, sometimes the foreign bodies may not be visible to us, but there will be a compatible history, and certain pointers will be there which will point to the presence of intraocular foreign bodies, such as an iris hole or a trajectory in the ocular tissues or signs of toxicosis. Next, we have the perforating injuries, where there will be both an entry and exit wound caused by the same object. And the object are usually very sharp, such as the needles, knives, and pellets. And common cause for perforating injury is a needle injury. While we are giving a retrobulbar or a peribulbar block with a longer needle and not taking proper precautions, we may perforate the globe at the posterior pole. The exit wound, however, in such injuries usually close by its own within 5 to 7 days, but it is associated with an inherent risk of high risk of proliferative vitreoretinopathy and retinal detachment. To summarize, ocular trauma is an important cause of blindness, and a proper terminology system should be followed so that a standard nomenclature is there, and the data can be accurately transmitted. Open and closed globe injuries have different pathomechanisms, and there can be a wide array of injuries that can occur after trauma, and prompt recognition and early intervention is important to limit the ocular morbidity. Thank you.